Mm. Hello.
Oh, hello. Who's this? Is this Pravin?
Yeah, I'm probably speaking from Kathmandu, Nepal.
Oh, you're from Nepal. Where are you from?
Okay, yeah.
You're from Nepal?
Yes. Well,
Welcome.
I'm from. Thank you very much. I have been attending this program as regularly as possible. I'm just trying.
Oh, you know, I was in Nepal. I was in Bharatnagar. I was in Kathmandu.
Yeah.
As a matter of fact,
Yeah.
we televised a show from Kathmandu. I found a cyber cafe that had really good internet in the Thames area. Is that what it's called? The Thames area?
Yeah. I remember you had been there, and I attended, many programs with you that time. I mean, the program of.
Oh, great.
Please.
Great. Great. Welcome.
Thank you, Professor. Thank you very much.
I think we're going to have a lively session today.
Yeah.
Because as you probably saw, I encourage people to bring cases.
Yes.
So we'll see. Hi, good. Dr. Duong is here. Okay, let me change. Hey, Duong, how you doing?
How are you?
Welcome.
Thank you.
Okay, I'm putting the background on. So how are things, Duong, in Vietnam?
Not too bad, but the number of patients increased.
Yeah,
Totally we have more than 1,000 patients.
per day.
Yeah.
Yeah, I just talked to Warlick's and she said there's variants strains coming out. Is it
Yes.
the same there?
Mm-hmm. In Ho Chi Minh City, the biggest city in Vietnam.
Yeah.
It in lockdown now.
Lockdown?
Lockdown.
Really?
Yes.
So no travel or everything?
Travel, yes.
Oh, great. Algeria, welcome to Algeria. Lockdown, wow. You're in Saigon or old Saigon, Duong? Weren't you in Ho Chi Minh City? Good morning. Good morning. How are you, Dr. Lanzino?
Good. Thanks. How are you?
Welcome. Welcome. Yeah, nice background.
Try to upgrade.
Yeah. If people will get more comfortable with the platform and doing what you want to do, interactive. Most of the ones I go to are not interactive.
Right.
You know, the speaker speaks to the very end and maybe a couple of questions. Well, that's it. So I think we're going to get some people. I think we're going to get some cases today.
Okay, good, great. Looking forward to it. Should I try my
Yeah, you want to experiment
here?
with something?
Yeah,
Sure.
make sure that
everything's working. Okay. Buenos dias, Victor.
Hello, Victor.
Hello, Dr. Lanzino. Nice to see you again.
Good to see you.
Congratulations for this academic program. Very good, especially for vascular neurosurgeons.
Okay, looks good. There's no sound, of course. Right?
Yeah, no sound, and then just the videos.
Okay, yeah, video is, it's going fine. You can see it, right?
How is the quality? Good.
Good.
There is no.
Good.
I
no,
mean,
it's
very
good.
good. Very good.
Very
Okay.
good.
Okay, then I think we are all set. I'll
Okay.
stop sharing.
Okay. Is Nicholas? I think we're
Yeah.
going to need Nicholas today.
Yeah, Nicholas is going to join us. He's going to help with the Q&A, and also he has some cases ready. So
Oh, great. Good morning, Nicholas.
Morning, everyone. How are you?
Very good. Welcome.
Thank you. Looking forward to it.
I think we may need you today as a navigator.
All right. Well, I'm ready to go.
Yeah, good, good. You got your game face on, right?
Yeah. I've had my coffee. I'm ready to go.
Okay. Yeah, me too. I had to make a special trip. Victor, how are things in Mexico City?
We were improving last weeks, but now we have increase of COVID, but
Yeah.
especially in people between 20 and 40 years old. So the old people is protected, but young people is increasing COVID.
And the cases aren't as serious in the younger ages, right?
Not as serious as the old people.
Well, you know, Victor, the variant strains popping up in Southeast Asia, in Thailand, and Tuong was just saying Vietnam,
Yeah.
and it's actually increasing.
Yes.
It's increasing. How is it in Nepal?
Well, in Nepal, currently the cases are getting less because in the whole South Asia, there was huge pandemic curve for almost 3 months from April to June. Basically, that time the center of pandemic was India and all the South Asian countries. At the moment, cases are getting less, but still we are having quite high what we call positivity. Even
Right.
though the total number is getting less, but it all depends on how many tests you do, isn't it? So
Right.
accordingly, the positivity is still high in our country. It is almost 20% every day. And more surprising is Bangladesh. It is getting worse. The situation is getting worse in Bangladesh recently, since probably last few weeks.
Okay.
And at the moment, the positivity in Bangladesh is, if I'm not wrong, according to Johns Hopkins University data, it is around 30%. A few days back, maybe yesterday or day before yesterday. So it is still South Asia is very, very vulnerable, including Nepal, even though the data shows less cases in India, Pakistan, and even Nepal. But we are still in highly vulnerable situation, and we are still having partial lockdown.
Yeah.
Yep.
Yeah, it's well, the United States is mostly Dr. Lanzino, 50% of the country is vaccinated now, and but there are still pockets where there's not vaccination, where it seems to be increasing. Yes, Benu, you want to speak, Benu? Go ahead.
Yeah. Hello, sir.
Yeah, good day. Welcome.
Well, thank you, sir. Of late, I've been seeing few complications after vaccination in my patients. Some patients who had headache before have had recurrence of headache. Those seizures who are well controlled with anti-epileptic medicines had recurrence of seizures, breakthrough seizures. And also one patient with a brain tumor, meningioma, whom I had operated, had a seizure after immediately the evening of vaccination. So definitely the pre-morbid conditions, even many patients with back pain had recurrence of back pain. And I recently heard a patient with a undiagnosed brain tumor has gone into coning and he's brain dead already now. So nothing can be done. So definitely the vaccines are not as safe as they are being projected, and they are causing significant
which vaccine? Which vaccine? Moderna? Which one? Pfizer,
no,
Moderna?
in India, we are using the Covishield and Covaxin, which both of them are having problems. So these antigen vaccines are creating a multiplication of the virus vector, which is increasing the antigens and causing thrombosis, which might be the reason for the complications. And even recently, a BBC reporter, she died of cerebral venous sinus thrombosis. So this needs to be emphasized and propagated so that patients are cautious. And most of these patients who had complications, I put them on ecosprin, clopidogrel, and a small dose of steroids for 1 or 2 days, and they have done better. So such sort of a complete picture and truthful education of the warning to all the patients should happen from we as neurological faculty, so that our patients don't suffer problems. And also the compulsory vaccination which is being done should be countered in a significant way. Otherwise, because the further risks which are unknown, like infertility and even the mRNA vaccine complications of genetic alterations, we don't know. It has not been studied. And given one video clipping of Bill Gates saying that if we can play with the healthcare and the vaccination, we can bring down the population to 4 trillion, is such a drastic statement. And why are we not active against it is the question. Why the medical fraternity is not countering the popular narrative of compulsory vaccination?
Yeah, I guess the first step is publicizing it. Get it known what's going on, like you're doing now.
Yes, sir. Thank you, sir.
Yeah.
We should tell the policy makers, because I've been trying to communicate with them. They are like stone-hearted and stonewalling themselves. So as a faculty, as a group, we can spearhead this awareness and change in the policies. Is it compulsory in your country, sir, for vaccination, or people can opt out of it?
Well, the country is about 50% vaccinated. There are pockets where people refuse, and that's the area where it's increasing. The COVID's increasing, obviously. So we're lucky. We're lucky in this country. The fact that we, well, I had Pfizer. I don't think there's been a problem with Pfizer. Has anybody heard of problems with Pfizer? Pfizer vaccines? I don't believe there has been.
Because
widespread, like yours, like it's not widespread, like you know, side effects that you're talking about.
Because we are using the AstraZeneca version of the vaccine, the Oxford University and AstraZeneca technology transfer to Indian companies, which is making the vaccine and giving it. So no.
Okay. Okay, we got 2 minutes, Dr. Lanzino.
Okay.
We have late arrivals.
Just before we go live, do you want me to be fielding questions as we go, or are we going to take a few breaks between some of the cases for the questions?
I don't know, what Dr. Lanzino, what do you prefer?
I think we can decide as we go, depending on the questions, depending on the issues. I would say, Nick, use your judgment. And
sounds good.
It'll be. Thanks. We're very relaxed and informal, so.
Perfect.
Yeah, I wish I could play music in the background, but it's, you know, Dr. Lanzino, it's all copyrighted.
Is that right?
Yeah, YouTube will shut you right down as soon as there's copyright music.
Wow.
You got to be careful.
Interesting.
Yeah. I've been in Portugal. I was televising, and they shut it down because there was background music in the auditorium.
Wow.
That was copyrighted. So they're funny sometimes. But of course, it's not funny if you're running a broadcast. Yeah, we're going to get a lot of people today. Come here.
So what I was thinking, I can get going with the case, and then once we are done, everybody, hopefully, then I can ask, I don't know if any of the other panelists have a case to present, and
Okay.
we can
Very
go that way, or.
Okay, very good. We're going to start now. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the honor of having Giuseppe Lanzino, MD, probably one of the most published neurosurgeons on this planet, giving a unique, a different kind of approach to interaction about the cases and an informal atmosphere, hopefully. And he's aided by Nicholas Borg. Hello, Nick. Good morning.
Morning.
Okay, Nick is going to help navigate the situation. And okay, just Dr. Lanzino, welcome, and it's all yours.
Good morning, everybody, or good evening for some of you. Thank you for joining us on this Saturday. And as we tried to do last time, we will start with some cases, and please feel free to interrupt. Oh, sorry. And we like this to be as interactive as possible, and then I'll start with the case. If anybody has other cases, we'll be happy to discuss some of the participant cases. Can you please confirm that you can see my PowerPoint?
Yes, we can.
Yes.
So, as I said, the spirit here is to start with the case and then discuss specific pathologies with some literature remarks. So this is a patient that we treated over this past month. Is a 61-year-old who had gamma knife for an incidental meningioma of the cerebellar point and angle. I think the treatment was done in 2017. And as part of the follow-up, she was receiving follow-up MRIs. And she has really no symptoms. And you can see here on the left of the screen, the MRI, the T2 from 2017. And then you will see the 2021, so 4 years later. And you can see that the meningioma is stable. There has been no change over 4 years. And I will focus our attention in this area, in the area of the vermis. And what you see here on this comparison of two slices, you can see here you see only one flavoid, and 4 years later, if you look carefully, you see more flavoids on the left side, and maybe something also along the ridge of the cerebellar hemisphere. As we scroll again, more flavoids noticeable on the left side, nothing major, but definitely in retrospect, a slight change. And then this is the reason why the patient was referred to me, is that you can see between 2017 and 2021, there has been development of a varix. And here you can see that the varix is in relationship with a vessel that was there before, probably venous structure, but has definitely increased in size and prominence. So very interesting development over time. So this, of course, prompted us to recommend an angiogram, and you can see here, this is a left vertebral artery injection lateral view. You can see here as we scroll, this is actually a distal a branch of the posterior inferior cerebellar artery. And here you can see the Vermian branch of the superior cerebellar artery. They all converge. And then there is, and you know, this is basically right immediately underneath the tentorium. There is a nidus that converges, a conglomeration of small arteries converges into this draining vein. And you can see then the draining vein down below, there is the varix that we saw on the MRI. This is an AP view. And you see like here the pica branch and this early draining vein, which emanates from the undersurface of the tentorium, on the immediately on the left of the midline. And then as we follow that vein, it goes down. You see the varix, and then you see that the arterialized venous system uses pathways that eventually goes into the transverse sinus. So, you know, we always discuss in medicine. We have a patient here. This is, of course, it's a dural fistula. So we have a patient with the two relatively uncommon problems: a dural fistula and the CP angle meningioma. And in medicine, every time we are faced with the patient that has two relatively uncommon problems, we always question, is there a relationship? Is there a potential relationship between a pre-existing benign tumor and the development of a dural fistula? So that's one point that I like to, and actually, since we had seen this over and over in the past, we had studied, and a few years ago with my friend and colleague Greg Ziffel from WashU from University of Washington in St. Louis, we did reported these associations between dural fistula and benign tumors, particularly meningioma. The idea being that if you know, if you have we know that dural fistulas are secondary to venous hypertension. So the idea being that if you have a compression of a vein, in this case, I hypothesized compression of the vein part of the petrosal system, then you have a relative local hypertension, which indeed might lead to the development of dural fistula. And when we think about dural fistulas, there are two theories. Is the arteriovenous shunt the result of local decrease oxygen tension and the relative ischemia, or is the formation of the dural fistula related to reopening of what some people feel are pre-existing arteriovenous shunts within the dura, which are referred as the so-called corpuscle of Manelf? So again, I think here it's an interesting potential correlation. The other issue worth discussing here is that if we look at the literature, there was a meta-analysis done by Samawad in the early 90s about dural fistulas. He put together all cases of dural fistulas that were reported up to that point. And this is a tentorial dural fistula. Interesting in that meta-analysis, over 90% of tentorial dural fistulas it presented with hemorrhage. Now, 30 years later, at least in my practice, the vast majority of tentorial dural fistulas that we found are in patients like this lady that is completely asymptomatic or after symptoms other than hemorrhage. So there is another interesting progression and evolution somehow of the disease, of course, related to the fact that now patients are investigated with advanced imaging very early on when they present with minor symptoms. I don't know if we have any question or any comment at this point. There are other interesting issues with this particular case. Is that one is that we have seen now a couple of patients with dural fistulas fed by distal branches of the posterior inferior cerebellar artery. And while the dural branches of the superior cerebellar artery are known and have been discussed in some publications recently, we couldn't really find much about dural supply from distal branches of the posterior inferior cerebellar artery. But of course, there is a lot of variability. And the other thing is that there might be dural branches from PL vessels that are very difficult to study in the normal cadaver. And I know Hugo has done a lot of work in on the vascular anatomy, but I think one of the issues is that there might be branches, but they are so small in the normal brain that might be very difficult to study in cadaveric preparations. Of course, when there is a dural fistula that is a low pressure shunt, the AV shunt is basically sucking blood from everywhere, and therefore vessels that are normally very, very, very small, they become much larger because they, as we know, the diameter of a blood vessel is related to the flow demand from that particular vessel. So the next question is, well, what do you do in this patient? Well, I think here that, yes, the patient is not symptomatic, but we have been able to document that there has been a interval development of a venous varix, which somehow indicates some degree of venous outflow, increased resistance. And therefore, we know that this is one of those factors that eventually leads to the development of hemorrhage. So in this patient, we would recommend treatment, even though she does not have symptoms. Now, another interesting aspect of dural fistula that is well exemplified by this case is that unlike intracranial aneurysms, where there is, of course, a close correspondence between the site of rupture and the location of the pathology, in dural fistula, the bleeding often is distant. When there is a bleeding, the bleeding is distant from the actual site of the fistula. And you see in this particular patient, the site at highest risk for bleeding, it's at the level of the varix, which is actually remote from the actual point of fistulization. So this is also brings us to, of course, we like as much as possible when we deal with pathology to classify these pathologies. And there is no question that when we think about tentorial dural AV fistulas, there are certain angiographic and anatomic commonalities, and this is what has been referred to as a medial posterior tentorial dural AV fistula. And I will show that these fistulas, they tend to have appear the same when you do surgical exploration. The supply is also often from branches of the superior cerebellar artery. There are typically branches from the posterior meningeal artery, one of the branches of the extra cranial vertebral artery. In this case, as we saw, there was it was actually from the posterior inferior cerebellar artery. But these are they have and commonly and typically they are located. The early draining vein comes from the undersurface of the tentorium, close to the midline, but usually off to one side. So I think we are in agreement that these patients should be treated because of the interval development and of a varix and the risk of bleeding. And then when we think about treatment, we have surgery, radiosurgery, and embolization. Surgery, we can keep it for later because that's what we did in this case. But what about radiosurgery? Well, we have a very large experience of radiosurgery for dural fistulas, but we use radiosurgery for the transverse sigmoid sinus dural AV fistula, and is an incredibly effective treatment. For reasons that honestly we don't understand, radiosurgery is not effective for this type of dural AV fistula that have exclusive retrograde venous drainage. So it doesn't really work very well for the ethmoidal, this one like the tentorial, and as opposed to the transverse sigmoid sinus or the ones involving even the superior sagittal sinus. The other issue with the radiosurgery is that, as we know, when it works, there is a latency time, and this patient, we have seen the interval development of this varix. So there would be another reason why I don't think radiosurgery would be a good choice for this particular case. What about embolization? There is no question that the endovascular treatment is now the modality of choice for the vast majority of dural fistulas. Most dural fistulas can be treated effectively with endovascular embolization. And I think that in this particular case, it would have been a reasonable choice because the feeding arteries have a relatively straight course, which would have allowed a fairly simple catheterization, and more importantly, would have allowed us to get very close to the actual AV shunt. We balanced that with the the fact that we felt the surgery was a fairly straightforward solution in this patient. The embolization, as I showed, there was supply to the fistula from PL vessels, and you worry about, especially using liquid embolic agent, about the reflux and liquid embolic agent going into normal vessels. And the other issue with the embolization is that after the embolization, if when you go and pull the catheter and you are so distal, there is always a small risk of causing hemorrhage, even though nowadays we have this microcatheters with the detachable tips. But there is no question this would have been a fairly reasonable and most likely effective solution. But we felt that surgery was definitely not quite as convenient from a patient point of view than embolization, but was a very good solution in this case. So we do this in the sitting position, and we do a midline suboccipital craniotomy. And I like to make an incision in the dura in the most inferior portion, open the cisterna magna, let the cerebellum drop, and then once you have the cerebellum dropping. So here we're looking at the patient from the back, and what you see here, this is the it's a midline incision. So this is the falx cerebelli here. So this is the left side, left cerebellar hemisphere. Vermis would be here, and this is the contralateral side. And you can see that as we expose from the left side, we see the most proximal portion of the large draining vein emerging somewhere from underneath the tentorial surface, slightly off to the left of the midline. Now here I'm cutting the falx of the cerebellum just because I want to get I want to get as proximal as possible to the attachment of the arterialized vein. And also I wanted to have a circumferential view of the arterialized vein in order, and you can see ICG fluorescent is very helpful. And as we know with these dural fistulas, once you decodify the dural fistula and you identify the precise location of the proximal portion of the draining vein, then the treatment is fairly straightforward. So this is a classic appearance of a so-called medial posterior tentorial dural AV fistula. I don't know if there is any comment or any question at this point.
We haven't got any questions from the chat, but I've got a question for you, Dr. Lanzino, if that's okay, which is when you first opened up and you saw the vein, it's tempting to say, why don't just snip it there if you know that that is the arterialized vein? Can you just expand a little bit about why it's so important to follow it all the way to its dural origin?
Yeah, it's important to really as we know, the death of a dural fistula, it's really the interruption of the most proximal portion of the arterialized vein. The other thing is that it is important to get to the point, and it's also sometimes you can come across more of a distal portion of the arterialized draining vein, and you might get a false impression that it's the point of the proximal shunt, while the actual shunt it's a little bit more proximal. And of course, if you interrupt the arterialized vein, but not very close to the site of shunt, but more distal to it, then of course that can have catastrophic consequences. So I think it's very important to make sure that you get as close as possible to the actual point of emergence of the arterialized vein from the dura. And also, I like to have a circumferential view of the arterialized vein to make sure that there are no branching points.
Perfect, thank you.
I'll go quickly to a very similar case, just because I like to stress the fact that once you see a few of these fistulas, they do have actually, in relation to the location, they have a fairly common appearance. This is a fellow in his 60s that we treated a few years back, and it presented with progressive imbalance, nausea and vomiting. And you can see that there is some cerebellar edema. And there was a suggestion on the MRI that there were some dilated veins. And look at the similarity. This is a lateral angiogram. Again, this is the most typical feeding vessel. It's the distal branch of the posterior meningeal artery, and you can see, you can kind of make the tentorium here, and you can see that there is somewhere the point of fistula right here. One practical trick is that how do you tell on the angiogram where is the actual point of fistulization? Sometimes these angiograms are not so easy to interpret, but the point of fistula you can recognize because you see the transition from an artery that typically tends to taper as it goes distally. So the artery tends to get smaller as it goes distally. And then all of a sudden you see a larger area, which indicates the origin of the draining vein. And you can see here as the arterialized pressure transmitted to the vein creates these tortuous distal veins, what has been described as a pseudophlebitic pattern. And you can see how the venous return in the cerebellar hemisphere, especially on the left side, is impaired, and the edema and that we saw on CT and the patient symptoms. But you can see the striking resemblance of this posterior medial tentorial dural AV fistula with the draining vein, which, and here is the, edited video of this case. Again, midline suboccipital craniotomy, patient in semi-sitting position, the cerebellum drops, and here is the falx cerebelli. And you can see that there is, and here you can see why it's important what we were discussing before, to really separate and identify the point of attachment, because this arterialized vein has a branch that goes anterior and the branch that goes posterior, but there is a common trunk of emergence that is right here, and you will see in the video. So that's, exemplifies. So here you can see this is the left side, this is the right side, and now the falx cerebelli has been cut. And you can see how in this case, just disconnecting this part would have left the fistula alive, because from the common trunk, there would have been anterior drainage. And you can see pre-clipping the arterialized vein. After clipping, there is no early filling of the arterialized vein any longer. So you can see how the commonalities, both on the angiogram as well as intraoperative findings. Now, this last case, you can tell that the vein was harder. So this probably was a more of a long-standing case. while in the previous case, you could get the sense that the vein was, yes, arterialized, was red, but it was not quite, the wall was not quite as strong as the last case. And that because in the previous case, the fistula, it formed over time, and that was not quite as long-standing and well established. If there are no other comments, we can I can go on and we can show again. Then there is a different type that is the so-called. So it's still anterior. Sorry, still medial, close to the midline, but the fistula is much more anterior, in which case it will involve the drainage through the Galenic system. So these have been defined by Michael Houghton as a Galenic type. And this they can present in different forms. Here we have a case where there was involvement of the entire Galenic system, and this patient was treated with embolization. Now, one of the interesting aspects of dural fistulas is that really they can present with different symptoms. This patient had presented with hydrocephalus. So you see the hydrocephalus, and you see here the fistula and the compression probably of the aqueduct plus the venous hypertension. Now, here you could say, okay, the patient is symptomatic from hydrocephalus, so why you didn't treat the hydrocephalus first? Well, for two reasons. Number one, if we think about the kids with the vein of Galen, we know that treating the hydrocephalus before you treat the vein of Galen can be dangerous. But also, I would have, in this patient, I would have been very worried about treating the hydrocephalus in the setting of a situation of increased venous hypertension and distended veins. So here you can see how you can decodify the anatomy, because the branches, dural branches that normally are very small, are dilated. This is a case that I did with my colleagues in endovascular, Dr. Kloft and Dr. Bringigi. Dr. Bringigi is the one who edited this beautiful video. So you can see the middle artery, it's our friend from an endovascular point of view, because the vessel runs in the dura, and therefore it tends to be a straighter vessel than, for example, the other vessels like the superior STA that you can see as to adapt to the elasticity of the skin. So here I like to share a trick that we use very often now for this embolization of dural fistula, is that we use a distal access catheter, in this case a 5 French Sophia, and we try to really jump the catheter as distal as possible, not only because it provides us with the extra support, but also because by getting the larger catheter as distal as possible, we get a proximal flow arrest. So this acts like a balloon that has been used in the so-called pressure cooker technique of embolization. And you can see nowadays with the modern microcatheter, we can really go very close to the point of fistula using the middle artery. So in this case, the strategy is that since we have also the ability to access the fistula transvenously, the strategy is that to place some coils into the proximal venous varix, with the idea that the coils will trap any onyx that we will inject afterwards through the transarterial catheter, so that to prevent the onyx from flying through the high flow fistula. So here is a microcatheter run on the arterial side. from the catheter that is way distal into the middle artery branch. Here is the navigation of the venous catheter. And, you know, sometimes it's difficult, especially when there are tortuous veins, to find the correct pathway. But usually, as I said, the arterialized vein has a wall that is much tougher than the normal vein. So they tend to be fairly resistant to trauma from catheterization. This is the venous run from the microcatheter in the vein. And as I said, the strategy is to place some coils to provide the basket so that when you go and they start injecting onyx afterwards through the arterial catheter, the basket of coils, you can see now we are injecting onyx, and the basket of coils, it's preventing the onyx from flying through the arterialized vein. So in this case, we know that the entire galenic system is arterialized. It's not being used by the brain. And therefore, you can progressively occlude the entire vein of Galen, which is the main venous drainage of this fistula. You can see here there was a lot of reflux through the arterial catheter, but being in the distal middle artery, you can afford a lot of reflux, but that sometimes makes withdrawing the catheter a bit problematic. But again, you are in extracranial vessel, so a lot of traction, it's usually not a problem. And so this is, again, a tentorial fistula. This is a medial type, but is as opposed to the posterior ones that we saw, this is an anterior one. And these ones, they drain through the galenic system. In this case was the entire vein of Galen that was involved. Now, this is is another case. It's again an anterior medial fistula, tentorial fistula of the galenic type. Interesting to note is that how the vast majority of these fistulas, they tend to occur and involve the infratentorial space rather than the upper surface of the tentorium. Now, this is a 44-year-old. This is a patient also that we treated recently, had presented with increasing headaches. And on the MRI, you see on the MRI, often you have indirect signs of the presence of a fistula. You see there is a large vein. This would be the equivalent of the vein of Rosenthal, and you can see how you follow on the MRI, this vein becomes more dilated. And again, you see the beauty of the classification of these fistulas is that there is a close relationship between the location of the fistula and hence the classification and the supply of the fistula. So here it's a dilated branch of the middle artery that goes into a proximal retrograde draining vein. And you can make this is the equivalent of the vein of Rosenthal. And then this is the point when the vein of Rosenthal and probably anastomosis with the dilated lateral mesencephalic vein. And then you can see the retrograde venous drainage that proceeds anteriorly. This is interesting. It's an AP view. Again, shows that there is convergence at the level of the arterial supply, the level of the midline, and then there is the retrograde draining vein. But look at this very carefully, because this will be interesting then with the surgical correlation, is that there is drainage through the main vein, but then there is delayed drainage through the contralateral. You can see here it's smaller, but there is a contralateral vein or Rosenthal that goes into the Galenic system. Now, interestingly here is that the drainage is down through the vein of Rosenthal, but the vein of Galen is involved by the fistula only in a delayed phase. And it's very interesting how this fistula, somehow there is a disconnection right here. And the vein of Galen is actually still used also by the normal brain. So in this case, the surgical strategy or the therapeutic strategy is to occlude, as you can see, is to occlude the proximal trunk of the early draining vein. This was a little bit difficult to decodify, but again, once you identify the type, then you know the pattern of drainage. Again, there is some supply here from dural branches of probably the posterior cerebral artery, as well as the superior cerebellar artery. Here is the CTA was very helpful, because the CTA clearly lets you identify the proximal portion of the early dilated draining vein, and you see how it's right at the point where it enters the Galenic system. Again, on the angiogram, we were able to see that the vein of Galen was not arterialized, but was used by the normal brain. So everything somehow, all the arterial supply, the AV shunt, it's somewhere at this level. So here, again, indication for treatment, it's patient has symptoms, new onset of headaches, as a retrograde venous drainage, which we know it's a risk for future risk of hemorrhage, as well as development of more neurological signs and symptoms. When you decide to treat a young patient with symptom and this fistula, then again, the question is what type of treatment. And again, here, as we discussed, actually, this was referred to me by my colleague who does gamma knife, because as I said, that we know gamma knife does not work very well for this particular subtype. And then the question is, would you do embolization? Or I thought embolization, this would have been probably our best venue, but you can see it's a fairly tortuous vessel. And honestly, in this case, I was a little bit worried about understanding very well the actual fistula because of the involvement of the Galenic system. So we consider surgery. Then when you do surgery, in this case, what kind of approach? Because this is a fistula that you could potentially treat. This is, we said it's on the left side. And so one approach would have been a posterior interhemispheric transtentorial approach, would have taken you right there. Or the other alternative, which is the one I chose, was to go supracerebellar infratentorial. And I felt that was a better choice because, again, I want to get a better understanding of the exact point of fistula. And I thought I could have seen from below, I could have had a better view of this area, but also of all the other tributaries of the vein of Galen, also on the contralateral side. So again, a semi-sitting position, medial suboccipital craniotomy. And now, again, I like to take a small opening in the cisterna magna that will drop the cerebellum. So now you see that you have a plan, but often the plan, as I open on the fistula, it's on the right side. On the side of the approach, you can see that there is this bridging vein, and you can tell that this bridging vein looks almost a little bit arterialized because it's, of course, this is while under normal circumstances, it is said that you can take a medial bridging vein. In this circumstance, of course, this vein has important, it's very important in the drainage of the normal cerebellum, drainage that has been altered by the presence of the fistula. So I had on purpose open all the way laterally, because then I went through a lateral paramedian trajectory. You can see here now opening the arachnoid and above the fourth nerve. So the fourth nerve, you can see it's right here. So you can go above the fourth nerve, protect the fourth nerve, and you can see that the large arterialized vein then comes into view. So here is the arterialized vein has been exposed. Here is the point where it enters the Galenic system. And you can see that, so this is the right. On the left side, now I was confused here a little bit because I saw another arterialized draining vein. But again, if you go back to the angiogram, this arterialized draining vein is on the contralateral side, is nothing but that secondary drainage involvement of the contralateral veno-rosenthal, which we had seen on the AP angiogram. So the ICG fluorescein here, again, is the main arterialized. You see the ICG fluorescein unequivocally. This is the proximal arterialized draining vein. And as you let the ICG run, then only in the delayed fashion on the other side, you see the contralateral veno-rosenthal, which is not directly involved, but only indirectly involved by the fistula. And you can see also how here is a pure arterialized vein, while on the contralateral side, that surgery looked like a arterialized vein, but there is mixing of arterial and venous blood. So while it's safe to take this one, of course, it would have been a catastrophe to take the contralateral side, and it's absolutely not necessary. So once I was sure about having identified the proximal portion of the draining vein, I placed a temporary clip. And look, interestingly, as you clip the proximal draining vein, look what happens to the distal portion of that large arterialized vein, immediately collapses. Then we did another ICG fluorescein, and now you see that there is no filling of the early draining vein, and you can see that the contralateral veins now fills in the late venous phase. And then once I was sure of that, I put a bayonet clip on top of the temporary clip to close the fistula. So this again, I found fascinating. I really get excited about this pathology because it's so fascinating in terms of the arterial supply, the commonalities between when the fistula is in relation to the location, the fact that they can really present with any symptoms or sign known to mankind, because it's not a focal arterialized territory. It's a venous problem, venous derangement, and therefore the symptoms can be quite different, and at times they can be very difficult at the beginning to diagnose. But then the beauty is that once you understand, then the treatment is fairly straightforward. Any question or any comment? So we have seen the posterior medial type. We have seen the anterior medial Galenic type, and then the last subtype of infratentorial dural fistula, it's the lateral type, and even there are many commonalities, and if you want, we can go ahead, and I have 2 examples of that. So that really, once you see we understand the pattern, then the treatment is pretty straightforward. Now, as you can see in this, the last example, it gives you a little bit of pause before you put a clip on, in this case, the vein of Rosenthal. I operated a couple of patients with a drainage of the Galenic through the vein of Galen, and to put a clip on the vein of Galen, it's of course, but once you identify the arterialized vein, and on the angiogram, you can be sure that the brain is not utilizing, and you can identify the exact point of emergence of the vein from the dura, immediately distal to the AV shunt, then again, the treatment becomes straightforward. But in this particular case, you can see why I really wanted to make sure as much as possible that I had a good view of the entire venous anatomy, that would not have been as straightforward from a unilateral supratentorial transtentorial approach.
Dr. Lanzino, we have a question from the audience. It's from Pawan. Pawan, do you have access to a microphone to ask your question, or shall I do it on your behalf?
Oh yeah, I see the question. It's about, is it possible to coagulate and disconnect the fistula instead of applying a clip? Absolutely. And I like to, in one of the case, I think the first case, actually, that's what I did. I applied a temporary clip. Then I do the ICG run, make sure that there are no major change, that I'm interpreting everything correctly. And once I know for sure that that's the target, then I go ahead and coagulate. The other thing with the using a clip as opposed to coagulate is that a dural fistula, it's really the only case where I can say that I've seen a permanent clip applied to the point of fistula that slipped in the immediate postoperative case, because sometimes some of these arterialized vein, if the fistula is long-standing, the arterialized vein can be extremely calcified, and applying even a permanent aneurysm clip might not be enough to completely occlude the vessel. So yes, coagulating vein is another strategy that I actually use more often than not. But there are situations like, for example, to coagulate the vein of Rosenthal in this setting. I think with the clip, I felt I had the sense that I had a little bit more control. The other thing is that when you coagulate, it's very important that as you coagulate it, you're very careful not to be too aggressive, especially at the point of emergence from the dura, because if you avulse the vein at that level, of course, you can trigger some bleeding that in a deep field can be difficult to control. But I have no preference, either the clip or the coagulation. Of course, the coagulation, you coagulate and divide, and then you know that it's closed for sure. If you apply a clip, you better make sure that the clip is in very good position and it's adequately closing the arterialized vein, which is not always the case if there are calcifications and so forth.
Dr. Lanzino, this is an amazing lecture. Excellent pictures, videos are really, really excellent, and this is very useful to neurovascular surgeons. I have just one question. We know that endovascular approach are the primary treatment for most dural arteriovenous fistulas. So why, which is the reason you decide surgery or
Yes.
endovascular? And do you prefer to make a transarterial or transvenous endovascular approach, especially in these deep fistulas, for example, Galenic fistulas?
Yes, it's I agree that when we looked at our series, now we have over 250 dural fistulas. Overall, embolization is by far the most common therapeutic modality. I think the embolization, though, risk as also, which is fairly low for the vast majority of these fistula, has to be weighted against what are the risk of surgeries. As you can see, once you understand the fistula and you know where to find it, the treatment is really pretty straightforward, the surgical treatment. So there are no general terms, and of course, this is a continuous evolving field. In the last case I presented, we could have tried, but I wasn't sure that we would have been able, given the tortuosity of the arterial system, to get very close to the point of fistulization. In general terms, when a fistula it's close or it's involving the brainstem, then we tend to be very, very cautious. For example, craniocervical junction fistula, we hardly embolize because of all the implications. So it's again, it's a field in continuous evolution. There is no question that the choice is subjective in some situations. Of course, for the purpose of the presentation, I chosen on purpose some surgical videos because the surgical videos allow you to actually see the fistula as opposed to on the endovascular side, endovascular examples, you see only the angiographic correlates. In terms of your second question about the preference versus transarterial versus transvenous, I think it all depends. Nowadays, with modern catheters and liquid embolic agents, you can embolize a large number of fistulas with exclusive retrograde venous drainage from the arterial side if you can get distal enough that you are close to the point of fistula. And if often we use proximal flow arrest, as I said, I showed our trick to really literally jam the 5 French distal access catheter so that we obtain proximal flow arrest in the milameningeal artery as we inject onyx. Whenever there is the milameningeal artery, as I said, that's the endovascular friend because it's a relatively straight vessels. The caveat with the milameningeal artery, you have to be careful. Many of these fistulas are fed by the petrosal branch. The petrosal branch participates also to the supply, particularly to the facial nerve. And therefore, with the liquid embolic agents, as the agent starts going retrograde into some of the surrounding feeders, you might not see it, and that can be an issue. So that's a criteria that sometimes we use in deciding surgery versus endovascular. From a transvenous approach, I think that most of us have moved away from the transvenous occlusion of the fistula just because of the advances in liquid embolic agents. We do, in some fistulas with exclusive retrograde venous drainage, the transvenous route, it's not like in the last case I showed, that would have been quite difficult because of the tortuosity and the small caliber and the eloquence of the veins. We use the transvenous route nowadays, as I shown in that video, mostly as an adjunct to the transarterial route. Either, for example, for transverse sigmoid sinus dural fistula, we place a balloon in the transverse sigmoid sinus, inflate the balloon as we are injecting through the transarterial site. To protect the sinus, or in the case I showed, to provide a basket of coils that will trap the onyx so that as you are injecting transarterially, the material will not fly through the high flow AV shunt. So it's, again, this is also part of the beauty of the disease, that when you have different options, one of the most difficult and at the same time interesting part of the entire process, it's really how you approach and which strategy you choose in the individual case. So it's not always a straightforward approach.
Thank you, Dr. Lanzino. Thank you.
Dr. Lanzino, we've got some more questions, if that's okay.
Yeah, go ahead.
So the next one comes from Enrico in Indonesia, who firstly thanks you for an excellent presentation. And then the question is, what type of clip and what specification of clip do you use for these cases? And do you have any other tips or tricks for endovascular and open young neurosurgeons?
Yeah, the clips that we use are regular aneurysm clips. If there is intraoperatively, if there is any question, like in the last case, I like to apply a temporary clip, which is something that you can always remove if you see any change, or if you feel that you might not have you find out you might not have interpreted correctly the pathology, and then of course, place a permanent clip. I often use a temporary clip confirmed with ICG fluorescent, and then coagulate the 2 stumps and remove the clip. I think in terms of the particular tips and tricks for end or open young neurosurgeon, I think if the specific question refers to the to the case of dural fistula and tentorial dural fistula specifically, as I said, it's like a careful balance of the pros and cons of each approach. And it's not uncommon that, for example, we, of course, as much as possible, we try to fix the fistula from an endovascular approach. But we also, since we have in the many cases open cerebrovascular solution, we always are very cautious in the execution of the endovascular procedure to make sure that everything is proceeding safely, and we have a very low threshold if we encounter any difficulty or things are not quite as straightforward and safe as we like, to stop and to opt for a surgical. So I think, if anything, the main tip and trick, especially when you have alternatives, is to balance the alternatives, and by doing that, you can keep the procedure as safe as possible.
Excellent, thank you. Pierre, you've got a question. Are you able to ask it directly, or shall I go ahead? Okay, I'll go ahead. So the question from Biagio is, firstly, again, thank you for a stunning presentation, and then how reliable is intraoperative ICG in documenting the closure of the fistula in these complex cases, and what is your standard postoperative imaging?
Thank you, Dr. Nicolas, for reading my question. Thank you.
Nice to hear your voice. Thanks for joining.
Yeah, the ICG for fistulas, I would say it's, first of all, I don't think it's absolutely necessary. I do think it's the way I feel about any kind of technical adjunct to surgery. If it's safe, it doesn't add too much time, why not? So I think more than anything is that the ICG, once you interpret what you are looking at, the ICG gives me a feedback that my interpretation is correct. And I think it's like a postoperative imaging. It's nice to document that after you have occluded the point of fistula, there is no immediate, there is no residual feeling. So I would not 100% rely on ICG. Another trick is that, especially when you are dealing with dural fistula, you do a first run. Then before you do an additional run, you need to make sure that you know, because there is always some ICG, residual ICG in the that you can see. So there are a few tricks, but I feel it's it's fairly reliable in confirming that my interpretation of the pathology is correct. That's really what it confirms. It confirms what I think I understand, what I think I know once I get there. Now, postoperative imaging, of course, catheter angiography is the gold standard, but we are relying more and more on CT angiogram, especially in those cases where we know that we have closed the fistula and we feel very comfortable. For example, in the last case that I showed, the Galenic fistula that was treated surgically, that patient did have a catheter angiogram to confirm that the fistula was closed, just because those are more complex. So I think I don't we have moved a little bit away from routine postoperative catheter angiography, except in those cases where either we have doubts or the fistula is more complex. And of course, we want to have a definite confirmation that the pathology has been treated.
Thank you very much for your answer. The problem is that I discharged a patient like 3 days ago, and because he underwent a surgical closure of an ethmoidal AV fistula, but the radiologist said that there is a residual AV fistula. So maybe I will prepare the case for the next time and we can discuss all together. I just thought that can be a reasonable case to discuss about. And I did the ICG intraoperative, and there was no residual AV fistula because the arterialized vein doesn't have any fill.
Sure.
So,
well, ethmoidal dural AV fistulas are a bit tricky. I've had that experience too, and I think Dr. Spetzler years ago reported the case. One of the problems with the ethmoidal dural AV fistulas, though, is that sometimes they are bilateral. And so it's important to carefully analyze the preoperative angiogram and make sure that the venous drain, because often they have bilateral supply, but unilateral drainage. But there are situations where there is bilateral supply and bilateral venous drainage. Almost there are like 2 fistulas on either side. So it's very important to make sure that that could be that for ethmoidal dural AV fistula, it's one of the most common. I mean, it's not that very common, but when there is a post-op residual, often it's related to that issue.
Okay,
or can be related.
Case for the next meeting, so we can discuss it together. Thank you very much.
Okay, Banu, did you want to comment about prevention of vascular problems?
Yes, sir. Thank you for the opportunity. Actually, I've operated few cases of posterior fossa AV fistula, spinal AV fistula, and anterocranial fossa AV fistula also. But I don't do endovascular procedures myself, but my colleagues do, and I have observed. In many of the patients, what we saw was there is some sort of a sinus occlusion nearby, sigmoid sinus or a superior petrosal sinus, or even in the spine, we don't study the venous drainage, but maybe an epidural thrombosis or something. But so what, and of other cases of headaches and which had some history of early morning heaviness of the head with giddiness, tinnitus, where I looked, where I got a MR venogram done, I used to see a lot of sinus thrombosis in the superior sagittal sinus or the sigmoids. And those patients, when I put them on ecosprin and Diamox to decrease the ICP and ecosprin to improve the blood circulation, and if there is strong correlation to the laterality, I used to add anticoagulants like warfarin or of late dabigatran. So I have seen very significant improvements in the headache or the symptomatology. And projecting onto that, where would be the cause? In one auto driver who is into with a lot of pollution, he had a sigmoid sinus thrombosis which opened up later, and then which had recanalized in the subsequent MRI, and again had a thrombosis with some recurrence of symptoms. So this dynamics of thrombosis because of pollutants, pesticides, preservatives, plastic, and even the paints in the indoor, what the pollution, indoor and outdoor pollution, what we speak of, all these things need to be controlled and needs to be regulated. I think we need to, as a endovascular body, we need to suggest these things for the policy makers to prevent these diseases, the subtle thrombosis and their complications. And of late, I have been adding ecosprin to all my patients, be it cranial or spinal, with whatever problem. And anybody who needs surgery, I avoid them for till 3 days post-op, and I start them on anticoagulants and antiplatelet agents. And the second thing is we need to be more advocative for healthy lifestyle with good amount of hydration, something like forest food or organic food to prevent and decrease in the carbohydrate intake. So this is all my thoughts about primordial prevention of problems. So thanks for the opportunity to speak. Thank you, sir.
Thanks. If we have time, I'll show two cases of lateral tentorial dural AV fistula again to show and identify the commonalities and the fact that really after you see one, then you can recognize the pattern. I apologize, I think I presented this on one of the UR rounds that I did on dural AV fistula, but go quickly through this case. A 69-year-old presented with imbalance dizziness for a year, had diplopia for 6 months. You can see dilated veins in the cerebellum. So this is another indirect how to distinguish a fistula from an AVM. You know, in a dural fistula, you see in a AVM, of course, you have a more compact nidus, and you can have very complex draining veins, but with the fistula, you see, you see a diffuse, dilated, tortuous veins with often a few varices here and there. And you can see here, again, this is the point of fistula. You can see on the MRI, it's typically along the petrous ridge. And typically these fistulas, the early draining vein, it's nothing but one of the branches of the superior petrosal system. So this patient actually was embolized elsewhere, but they could not get complete occlusion of the fistula and was sent to us. And you can see here again, typical appearance of these fistulas. They can be quite intimidating if you look at the angiogram. But again, once you know you identify the type of fistula, you identify the location, then as I said, in this case, and you know that they are always along the petrous ridge. In this case, you can, based on the MRI alone, you can identify the point of fistula. But I'll go fast because the point here is really to show the intraoperative findings. Now, okay, so this is a retrosigmoid approach, and you can see once you get to the level of the petrous ridge, this is the tentorium. It's often at the junction of petrous ridge with the tentorium, and you can see all the arterialized dural arteries converging into a large venous varix. Again, as I said, the ICG, you see this is the distal portion of the main draining vein, and you can see nicely the venous varix. And again, this is a typical, I'll show another case afterwards. This is a typical appearance, is the large arterialized draining vein emerging at the dura at the point where all these small arterialized, these small arterial dural feeders converge within the dura, and then there is the main draining vein. And again, once you identify, there is no question, this is the point of fistula, and you can see again here, if you don't expose the point that Nick was making earlier on, if you don't expose the actual point of fistulization, you can see there is an early bifurcation of this vein. You put a clip on this portion here, and then the fistula might be still active through the other branch. So here again, the importance, and there is a small common trunk, and here is the clip application. Here it's one of those situations where, of course, I like to use a clip because trying to coagulate this very short common trunk would have been quite problematic. And again, this again to show like that once you identify these fistulas, the solution it's fairly straightforward. And here how we rely, as I said, here you can see that there is, this was read as a intracranial hemorrhage. It's not a hemorrhage. This is a thrombosis on the plain CT of the venous varix that we had seen on the MRI. And this is onyx, you can see from the previous embolization. And here you can see at follow-up there is a partial regression of the of this arterialized vein. So this is the pre, and this is the post-op. And here again you see the thrombosed venous varix, which has decreased in size after a couple of months. And one more, lateral tentorial dural fistula have exclusive retrograde venous drainage and typically involve the superior petrosal venous system. So, you know, once you see, you know exactly where to go to find it. This is another quick case. And once you see the intraoperative findings, so you can see the meningoepiphyseal trunk, transosseous branches of the posterior cerebral artery, you can identify nicely the actual point of fistulization along the petrous ridge on the CTA 3D reconstructions. And again, here is the point is that if you look at this, so here is the tentorium, here is the petrous ridge. If you look at this, it's exactly like the previous case. So the nice, the classification in this case as important practical repercussions, because, and then you can see here is the clip applied to the proximal portion of the draining vein. But again, if you remember the two cases, they look very similar in the typical appearance of the early draining vein. And that's once you see one and you memorize, then and you can see everything converges into that proximal portion of the draining vein. And this is, again, this is the classical appearance. Dural feeders converging into this large arterialized dura vein, which emerges from the dura. I'll stop here. Happy to discuss and answer questions if I can, or.
I think we've covered all of the questions from the audience so far, at least from the chat window. Does anybody else have any other questions or comments or anything that they'd like to share with us?
Hello, sir, when you apply the clip, is there a stump left behind which regrows? What is your follow-up experience?
I'm sorry?
When you apply the clip, is there a stump of vein, which is arterial vein, which, yeah. What is the experience with the regrowth of any regrowth of the stump?
Yeah, if again, of course, the idea is that once you interrupt the proximal portion of the draining vein, then the actual AV shunt has not been taken away. It's still there, but since you have removed the drainage, then the fistula regresses. I think early on, I did have a case where, you know, like it was one of those medial posterior tentorial fistulas where I saw what I thought was the arterialized draining vein. I placed the clip, and then on post-op there was residual because, again, I had not identified the vein right at the emergence from the dura. Usually we don't follow these patients for a long time because the understanding is that if the fistula stays closed after surgery, it's confirmed to be closed after 6 months, then I think it's closed. Now, with the endovascular, it's a little bit different because there are cases that have been reported of a recurrence of tentorial dural fistula after endovascular embolization. But in my experience, the cases that we have had when we do an angiogram at 6 months and the fistula is still there, then when we go in retrospect and we look at the immediate postoperative angiogram, we can see that there was still some very delayed shunt left. So I think that after surgery, if the fistula has been confirmed to be gone, and we are talking about dural fistula with the exclusive retrograde venous drainage, which means that there is one single draining vein emerging from the dura. Once that's closed, they tend to stay closed. With endovascular, it's a little bit different. We always tend to do an angiogram after 6 months, but I don't think it's actually recurrence of the fistula. The cases that we have seen where there is what we thought was a recurrence were usually cases where the fistula was not completely obliterated at the time of the first treatment. With the endovascular, especially with the onyx, you need to keep in mind that what the onyx does, it covers it layers the inner surface of the vein first. So you might, on the angiogram, you might have a false impression that the vein is occluded, where instead there might still be an inner channel inside the material that has coated the wall of the vein. So what we have learned is that after endovascular embolization, we are very careful in the interpretation of the immediate postoperative angiogram, and we make absolutely sure that we run we let that angiogram run very late in the venous phase to minimize the chance that we might miss a residual small persistent AV shunt. But after surgery, if you have an angiogram that shows the fistula is closed, then it's gone.
Thank you, sir.
Harshad, I believe you had a question. You want to ask that directly?
Yeah. Hello.
Welcome,
Hello,
Harshad.
Yeah. Hi, how are you?
Good. Hi.
Hi. Professor Lanzino, your lectures are always wonderful. Always there is learning, and I enjoy your talks and the way in which you present. I had a little query in this case. We are managing most of the dural AV fistula, especially in the region of tentorium or the parasagittally, endovascularly. Now, what are the cases where you want to operate without going to the endovascular first? And I agree, whenever there is a failure of endovascular treatment, you opt for a surgical treatment. In our experience, the endovascular treatment has really worked in most of the times. And there is one more patient recently I'm treating, and dural AV fistula at the parasagittal sinus. And patient is presented with a bleed in the parietal lobe and hemiplegia. And we did an endovascular treatment. Of course, his hemiplegia is still persistent, and slowly the clot is regressing. So what are the cases where one should go for a surgically?
Well, I think the case where you should go with surgery are those cases where there are risks from endovascular perspective. As I said, some of these lateral tentorial dural fistula, for example, are primarily fed by the petrosal branch of the middle artery. And there is no question that when you embolize through that branch, you do run a small but real risk of compromising the vascularity of the facial nerve. So for us, that would be an indication. Another indication is that in the sphenoparietal sinus fistulas, for example, one of the dangers of a liquid embolic agent is that as you embolize in the fistula, the liquid embolic agent might go through one of those dangerous external to internal anastomoses, or there are anastomosis with the ophthalmic artery. Well, for a sphenoparietal fistula, especially the lateral ones, you just do the craniotomy, you open the dura, and the vein is right there. So I think it's, of course, you can do surgical treatment for every fistula. You can do endovascular treatment for every fistula. But once you have both options, there are situations, and I do agree that there is also a lot of subjective, decision. Some people might feel one thing it's much safer surgery in that person's hands, or vice versa. But I think that every time you feel that there are perceived and real endovascular risks, you have to balance those risks with how difficult or how risky is the surgical procedure. So we look at patient age. A young patient is different than somebody who is in his or her 80s. We look at the anatomy of the fistula and the potential for compromising important tiny little vessels. For example, the ethmoidal ones, we still prefer to do surgery for many of those, because they are usually fed by ethmoidal branches of the ophthalmic artery, and you might run a small risk of blindness, even though I must say that nowadays with modern catheters, you can go far out enough that risk is very low. So it's a very difficult decision. There is no question. And the temptation is always, especially somebody like myself, I do endovascular and surgery. Temptation is always to go through the endovascular route, because there is no question that it's preferred by the patient. It's much more convenient for the patient, much easier on the patient. So, but at the same time, when I feel that in my hands that are real risk from an endovascular procedure, and the main, if you can never say the only issue with surgery, but by far the main issue is that the surgery, it's a little bit more inconvenient for the patient. Then when I have a doubt, I opt for surgery.
I agree with you. This is what happens in my practice. I am in a private practice. Whenever I give a choice for both surgery or endovascular, and most of the time patient opts for an endovascular treatment, and hence the surgical indications for us is going down and down, because the patient opts for it. They are ready to accept the complications from there rather than a surgery.
Sure.
So this is something which we face very often. Anyway, thank you. You have given a very comprehensive picture of a whole dural AV fistulas, and it's superbly presented.
Thank you.
I appreciate Lanzino. Yeah. Thank you. Thank you. Thank you very much. Thank you, John.
Okay, any more comments or closing comments or questions?
Yeah, I'm interested in Dr. Peret's view about the fact that the true vascularity of the dura has really not been adequately represented in the most anatomical studies. And Hugo, you have much more experience than I do with anatomical preparations. I thought is because in true anatomy, without any pathological conditions, some of these branches are probably so small that are difficult to adequately inject or prepare. And then, of course, when you have a pathology like a dural fistula, the branches have 100 times the normal size, then they are easier to see. But definitely with the dural fistulas, what we have learned that there is much more participations to the vascularity of the dura from branches that before, from vessels that before were exclusively PL vessels, were vessels that were exclusively going to the brain. I mean, right now, if we have been able to learn that there are, in the posterior fossa, there are dural branches from superior cerebellar, from maica, we saw this couple of examples definitely from pica. So I was interested in your view.
You're muted, Victor.
Yes.
There you go.
I think this could be interesting research about the injection of dural arteries, because, you know, I have an authorization to do this in a forensic institute of sciences. So we can do this in fresh cadavers. So we can inject the painting, the silicone, very diluted in order to inject very small vessels. So I think we can do that work here in Mexico City in the next months. Specifically inject the external carotid artery, to inject the middle meningeal artery, probably posterior vessels in the posterior fossa. So we can prepare that, Dr. Lanzino. I think that if we dilute the silicone and or some other paint to inject, we can get probably a spectacular results. So let's do it.
You know, for our friends and colleagues, Dr. Perez has the most beautiful and unbelievable injections and has been able really to dissect out, especially the vascularity of the spinal cord, in ways that had not been possible until now. So if there is anybody who is really able to help us to understand better the vascularity of the dura, especially from those branches that we thought were only going to the brain, definitely Dr. Perez has the instruments. And as we are discussing here, I was thinking, Hugo, I think we could do the next session, we could do a very nice correlation. We'll discuss the vascular spinal pathology, and we can have you show and go through your injections and through your arterial and venous anatomy, and then we can show cases. I think that would be perfect and would be a really nice, and it's really, vascular spinal malformation is one of those topics that has been rarely been covered in a lot of the webinars that we are seeing nowadays. So that would be an idea for the next one. We can work together with John.
Great. That's August 9th. So we'll get that prepared and get that ready.
I will be in Italy, so we'll have to probably find an alternative alternative day, because I'm not sure about the connection from there. Plus, in August in Italy, everybody's on vacation.
Oh yeah, everybody in Europe is on vacation. It closes. Europe closes.
So let's say in September we'll take a pause.
That will be fine. We'll be in touch. So
yeah, that will be great.
I would like to thank Nicholas for coming out and help moderate. And thank you, Dr. Lanzino, and thank all the panelists, Victor, Dr. Parak, and all the other panelists that asked questions. And we'll be in touch about the next date. But this was great. Thanks a lot, Dr. Lanzino.
Thank you.
Thank you, Professor. Thank you.
Thank you, Dr. Lanzino. I will be there in the next lecture. Preparing.
Yeah, we'll coordinate. Thanks.
Bye.
Thank you, sir.
Yes.
Okay, great. We're off the